Good afternoon. Hello. I'll start calling names. Good afternoon, everybody. And thank you for coming to our Grand Rounds this afternoon. I'm Diana Romero. I'm chair of the Department of Community Health and Social Sciences, and I'm extremely thrilled to be providing an introduction and welcoming our featured Grand Round speaker this afternoon. It is my great pleasure to introduce Dr. Camara Phyllis Jones, immediate past president of APHA, a position she said that she laments having to step down from, right? And former research director of social determinants of health and equity in the Division of Adult and Community Health at the National Center for Chronic Disease Prevention and Health Promotion. She received her medical degree from Stanford and completed 2 residencies following that, one in preventive medicine at Hopkins and the other in family practice at Montefiore here in New York. So she is a partial New Yorker. Both her MPH and PhD degrees are in epidemiology from Hopkins. As a family physician and epidemiologist, Dr. Jones's work focuses on the impact of racism on the public's health. She has sought to broaden the national health debate on social determinants of health, equity, and universal access to high-quality health care. As a researcher and methodologist, she has developed new ways for comparing full distributions of data in order to investigate population-level risk factors and propose population-level interventions. As a social epidemiologist, her work on race-associated differences in health outcomes goes beyond documenting those differences to vigorously investigating the structural causes associated with them. As a teacher, many of you may be familiar with her allegories on race and racism that have sought to illuminate a topic that is otherwise oftentimes very difficult for many to understand, if not discuss. Dr. Jones is currently on the faculty at Morehouse School of Medicine and at the Rollins School of Public Health and Marine. She is a member of WHO's Scientific Resource Group on Equity and Health and the National Board of Public Health Examiners. She has served on many boards. She has served on APHA's executive board, on the board of directors of the American College of Epidemiology, and on the board of directors of the National Black Women's Health Project. But this list is by no means meant to be comprehensive, just some highlights. So all that said, given our own school's commitment to social justice and health, I believe we are incredibly fortunate this afternoon to have Dr. Jones with us today. And so with no further ado.
Thank you. Thanks, Diana. I have this on. How is the sound? The sound is good? Great. And I believe that I need to stand here, even though, I don't like to necessarily be confined by a podium, but I don't think that I have a clicker. So I'm going to have to advance my slides from here. No, I've got to do it. This is timing. This is timing. So the first thing I want to say is that many of you are familiar with different parts of my work. So I'm going to be presenting some things that with which you're familiar, which means that I'm going to go deep. This is going to be our opportunity to go deep on some things, which means I can't do that by myself. I want to, rather than presenting 45 minutes of titillating ideas and then having you remember your questions and ask them in a line, I'm going to invite you to, at any time during this presentation, raise your hand if there's something that challenges your worldview or that you think is incorrect, or even if you say, oh my goodness, she's speaking my life, or if you even just want to give me an amen. I want all of that from you. So there will also be 2 times perhaps when I interrupt myself and specifically invite you for input. But at any time, if there's something that you want to say, please just raise your hand. And I think it seems like we're recording this, so then I'll just repeat your question if it can't be heard by everybody. So let's get started. Achieving health equity, tools for a national campaign against racism. Well, what is a national campaign against racism? When I was president of the American Public Association last year, I launched as my presidential initiative a national campaign against racism for the organization, and as many partners and community groups and all as would join us. And this has not ended. We have not yet established the anti-racism collaborative, kind of a working group structure that we want to have. It's not set yet, but it will be. And we actually at APHA have a www.apha.org/racism page which has some resources already. But when we do launch the anti-racism collaborative, which will probably be hosted by some other organization, but when we do launch that, it'll be there. But the 3 tasks of a national campaign against racism are to name racism, that is to say the word, then to ask, how is racism operating here? Because it's not like it's a cloud or a miasma that we can't get a handle on, but it's a system with identifiable and addressable mechanisms. And then finally, to organize and strategize to act. Now, for a group that's all about social justice, this may not be the most startling thing that you heard, but for many people, why is it doing that? Did it just do something up here? Okay, it just did. Okay, that's fine. Okay, as long as it was stable here. Okay, so for many audiences, I have to justify why I'm even talking about racism, especially to a group of people who's concerned about health. What does racism have to do with health? So I'm going to share with you several tools. The first is my cliff analogy, which describes different levels of health intervention and explains why we, as health people, must be concerned with racism and other systems of structured inequity. After discussing that for a while, then I will turn very specific focus on racism, provide you a definition, a few other stories, define health equity, talk about barriers in our society to achieving health equity, and then finally end with a few other specific tools. So that's the outline of what we're going to do. So here we are, levels of health intervention. Whoops! Boom. Somebody just fell off of this cliff of good health. And if that were you or somebody in your family, you'd be delighted to find an ambulance there at the bottom of the cliff to speed you on to care. But if you were concerned about other people who might come along that cliff, so if you were concerned about population health or community health or public health, you might ask yourself, what could we put in place as a health intervention besides just stationing lots of ambulances at the bottom of the cliff? And of course, somebody's going to say, let's put a net halfway down. That way, even if people fall, we can catch them before they get crunched up at the bottom. That is an excellent idea. But you know, the more you think about it, nets do have holes in them, so some people might fall through the cracks. But never mind that, let's make it a trampoline halfway down. No holes in the trampoline, but even if we had a trampoline halfway down that cliff, we might very well find ourselves with lots of people just bouncing up and down at half functionality, not able to really get back to the top of the cliff. So what else could we put in place as a health intervention? Well, clearly we need to be thinking about a fence at the edge of the cliff to keep people from falling in the first place. But even that fence has to be a very, very strong fence if there's a lot of population pressure against it. So what else can we do as a health intervention? We can move the population away from the edge of the cliff. So let me label these interventions that I've described so far, where the ambulance at the bottom of the cliff clearly represents medical care and tertiary prevention. So maybe there's some first-year MPH students who haven't talked about the levels of prevention yet. You know, we talk about 3 levels of prevention: primary, secondary, tertiary. Tertiary prevention is preventing complications from disease that's already manifest. So that's your ambulance down there, medical care, tertiary prevention. The net or trampoline halfway down, these are our safety net programs, which are often in our social services, as well as secondary prevention, which is all about early detection, screening programs. The fence represents primary prevention, keeping bad things from happening in the first place, and moving the population away from the edge of the cliff is about addressing those social determinants of health, the determinants of health and illness that are outside the individual, beyond our individual genes, and in fact, beyond our individual behaviors, where these social determinants of health are the context of our lives. They include individual context, so that would be individual education, occupation, income, wealth, so addressing poverty is a way of addressing social determinants of health. They include neighborhood context, so whether or not you can get fresh fruits and vegetables in your neighborhood, or do you instead live in a fast food swamp? Some people call it food desert, fast food swamp, same thing, right? Can you exercise in your neighborhood? Are there street lights? Are there sidewalks? How do the police react to people walking in your neighborhood? Are there jobs in your neighborhood? And even if there aren't jobs, is there transportation to a job? Quality of housing, education, all of that. So addressing adverse neighborhood conditions is a way of moving the population away from the edge of the cliff, addressing those social determinants of health. So with this diagram, you could take an outcome like infant mortality and say, well, what are the different health interventions for addressing infant mortality? Well, the ambulance might be our neonatal intensive care unit. And the net or trampoline, halfway down, would be prenatal care, screening pregnant women to identify problems early in pregnancy. The fence might be our women, infants, and children excellent maternal nutrition program. Moving the population away from the edge of the cliff might be excellent educational opportunities, so young girls don't have babies so soon, or maybe a living wage so that pregnant women aren't living in poverty. So this is a cute little diagram, if I do say so myself. We can have a community conversation about how should we be spending our health resources. But as lovely as this diagram is, even as powerful as it might be to go to the State House or even to Congress talking about prioritizing levels of health intervention, recognizing we need some of all of it, this diagram has, as I've presented it so far, has a huge fatal flaw. And the huge fatal flaw is that it does not yet equip us to talk about how health disparities arise. And we must talk about how health disparities arise. So let me ask you to keep the cliff in the back of your mind for a moment. We're going to shift gears for just a moment to talk about how health disparities arise, and then we'll come back to the cliff. So how do health disparities arise? Well, recognizing that there are many axes around health disparities, health disparities by geography, by social class, by race. Let me just talk about race, ethnicity, how racial ethnic health disparities arise, because these disparities have been present in our country for centuries, occur across age groups, occur across organ systems, and we unfortunately have lots of evidence about differences in the quality of care by race or ethnicity, even for people who are within the same healthcare system, or even for people who are covered by the same insurance. The Institute of Medicine back in 2002, which now seems like a long time ago for many of you younger students, but in 2002, the Institute of Medicine released its unequal treatment report, which pulled together what at that time were hundreds of studies. If we were to do the same thing now, it would be thousands of studies documenting that even within, say, the VA system, there might be differences in how vigorously your chest pain might be investigated or treated depending on your race, or differences for everybody in an emergency department and how much pain medication you might get walking into that emergency department depending on your, with a long bone fracture, depending on your ethnicity. But even that IOM panel that released that ground-shaking report for people, I'm a physician, people were really shook up. They were like, oh, no, I try to do the best I can. This was the first time we had shown the bright light of inquiry to see whether or not there were differences by race and ethnicity. It's important to shine the bright light of inquiry, students and faculty members and public health workers. We need to do that all the time. But even those IOM panel members said this is not the end-all and be-all of how health disparities arise, because some people can't even get into health care in the first place. So that's the second level at which health disparities arise, differences in access to care. But then I'm hoping that everybody in this room recognizes that health is not created within the health sector. So there's a third huge level at which health disparities arise, which are differences in the conditions of our lives, differences in our underlying exposures, opportunities, stresses that are making some individuals and communities sicker than others in the first place. And if you think about these three levels at which health disparities arise, differences in quality of care, differences in access to care, differences in underlying exposures and opportunities, you could actually think of it as a pyramid. Or better yet, honestly, we need to think about this as an iceberg, where the huge hidden base are the differences in the conditions of our lives. And then very often the same people who have been made sicker are frustrated because of limited access to the healthcare system. And then even the lucky ones who get into the healthcare system are sometimes further injured because of differences in quality of care. So now, remembering those three levels at which health disparities arise, we're going to go back to the cliff. But now we're going to recognize that we're really not dealing with a flat two-dimensional cliff, but actually we are dealing with a three-dimensional cliff. And at some parts of the cliff, there might be an ambulance there, but maybe that ambulance has a flat tire. So it's slow or goes off in the wrong direction. Or maybe there's no ambulance there at all, and maybe there's no net nor fence. And usually, at those parts of the cliff, the population is being pushed closer to the edge. So now, let me label these observations about our three-dimensional cliff with how health disparities arise. Where the differences in quality of care, that's represented when the ambulance is there, but it's slow or goes off in the wrong direction. Differences in access to care are no ambulance, no net, no fence. And differences in underlying exposures and opportunities are represented by the closer proximity of that greeny population to the edge. So now that we recognize that we're really dealing with a three-dimensional cliff, there's a whole new set of questions that arise. The first question, of course, is how did that cliff become three-dimensional in the first place? And that's usually because of historical injustices that are perpetuated by present-day contemporary structural factors. But given that the cliff is three-dimensional, we also need to ask, why are there differences in how resources are distributed along that cliff face? And why are there differences in who's found at different parts of the cliff? Why are the oranges back there in a way and the greenies being pushed closer to the edge? And when you start asking and addressing those kinds of questions, you're doing something that differs from addressing the social determinants of health, which we described as moving the population away from the edge of the cliff, addressing poverty and adverse neighborhood conditions and the like. When you start asking questions about the distribution of resources and populations, you're now talking about systems of power, these social determinants of equity, which include racism, sexism, heterosexism, regionalism, ableism, economic systems like capitalism and the like. So that actually, with this cliff analogy, I have distilled three different dimensions of health intervention. And if you go back to your junior high or high school geometry, where one dimension is a line, 2 dimensions is a flat plane, and 3 dimensions is space, well, along the line at the edge of the cliff is where we can display all of our curative and preventive health services right there. Ambulance, net, fence. In fact, you probably have the experience when you say the word health and somebody immediately jumps to health care or health services, right? And even the discussion about the Affordable Care Act, that was an edge of the cliff discussion. And, thank God we didn't repeal and replace, although the Affordable Care Act is not perfect. I mean, my God, taking away health care from people is worse than that. And even when we finally achieve universal access to high-quality health care, which should be our goal, we need to join the rest of the developed world in assuring health and health care as a right, not a privilege, and establishing not only universal health insurance, but a universal health system, I would say. When we finally get universal access to high-quality health care, that is still going to be an edge-of-the-cliff consideration. The reason that we must demand universal access to high-quality health care is not that that in and of itself is going to result in large and sustained improvements in health outcomes or the elimination of health disparities. We need universal access to high-quality health care because that's how a civilized society values all of its people equally. It's as simple as that. But when we do get that, we still can overwhelm any system if everybody's pushed up against the edge. So we must move into that second dimension that I can display here in a flat plane. We must address the social determinants of health. We must think about moving the population away from the edge of the cliff if we want to have large and sustained improvements in health outcomes. But the trick there is that if we're about moving the population away from the edge of the cliff without recognizing that we're really dealing with a three-dimensional cliff, we're at risk of moving some of the population but not all of the population and actually making health disparities worse. So we must acknowledge and address the three-dimensionality of the cliff and the social determinants of equity, which are differentially distributing populations and resources. We must address racism, sexism, heterosexism, ableism, all in all, capitalism, and all of these others. Amen. Thank you. If we want to achieve social justice and eliminate health disparities. So I want to take a pause right here. Often if I'm dealing with a general audience, I say, so now I've said the word racism 2 or 3 times, nobody fell out of their chair, let's go, right? But this is actually, I'd be interested in at least 1 or 2 of your comments or questions about this cliff analogy if you find it useful. How many of you were already familiar with the cliff? Everybody. Was it? No, not everybody. Who was not familiar with the cliff? Okay, so it's about 2/3, 1/3. Did you Was it interesting to hear it, first of all? Yes, okay. Ask me some questions so we can go deep. That's 2/3, yep. So when I say addressing the social determinants, that's part of the assurance function of government, I would say. So addressing this, but I mean, lots of people can pile in, communities can organize, whatever. But addressing the social determinants is, first of all, acknowledging that health is not an individual matter. And that's already a revelation for many people. Many people think that health, is your genes and then what you do, what you eat and what you exercise. Clearly, individual health behaviors are important. It matters what we put in our mouth, but we need to ask a why question. Why do some people put certain things in their mouth and other people put others? You have to broaden to these social determinants, right, to the context in which people live. But then the revelation in this thing, in terms of addressing the social determinants of equity, is it doesn't just so happen that some people live in certain kinds of communities and other people live in other kinds of communities. So we have to ask another why question, broaden our gaze again, and if the social determinants of health are the context, we have to say, why do we see the range of contexts that we see, here in New York City? And why do we see different people differently distributed in that? So an example of addressing the social determinants of health, some people might say, well, let's put in a bike path, or let's put in, let's do community gardening, or that's going to address the context. Addressing the social determinants of equity is about who's at the table deciding where we're going to have the bike path, or whether or not we need community gardens and where. Who's at the table deciding where we're going to have, liquor stores versus, whatever the fancy grocery stores are up here. I'm not even going to name any, So, so it's a individuals. I think that part of our issue is that we think that we're so narrowly focused on the individual in this country that we don't even think about collective action. So it's like, what am I going to do about the social determinants of health? Okay, well, maybe I'm working in the health department. Maybe I'll start some walking clubs, or maybe we do this. We, as a collective, as communities, as activated citizens, need to consider all of these things that are impacting our health, and then we can start addressing them. But then we also need to recognize that it's not for us to petition somebody else. Please put something in our neighborhood. That we need to demand seats at these decision-making tables. Because the mechanisms of all of those social determinants of equity are in the elements of decision-making, which are structures, policies, practices, norms, and values. Where structures are the who, what, when, and where of decision-making, especially who's at the table, who's not, what's on the agenda, what's not. And the structures are the who, what, when, and where of decision-making. Policies are the written how of decision-making. Practices and norms are the unwritten how of decision-making, and values are the why. So my analysis is that all of these systems of structured inequity, racism, sexism, operate through decision-making processes. Yes? Oh, here's a mic. I'm sorry. Yes, here's a mic.
You speak more about engagement then. When you talk these aspects, it's one aspect, but a lot of times it's engagement, where the populations we most affected are engaged.
Aren't engaged by somebody else, or aren't engaged in their own struggles, or aren't engaged how?
In their own struggles, in their own involvement, even the decisions that affect them directly. Like they almost.
You think that they're uninterested?
No, I just think somehow they're not being pulled in.
Not pulled in. Okay, so I got you. So I would say that two things. First of all, there's so much going on in communities. People are trying to solve their problems all the time. But maybe they're not trying to solve them in the way that we think they should solve them, right? And so then we're trying to pull them into something that we thought was a good idea, and they're busy over there trying to do something else, right? Like they're trying to start a dance club or something, and we're trying to make them walk, or they want a soccer team, and we're trying to make them do something else, right? So that's one thing. Also, sometimes people are really busy, like overwhelmed or tired, so there are a lot of reasons that people don't activate, but the core thing is we in this country don't raise our people to be citizens. So our educational system is geared, especially for certain people, to create consumers not citizens. So we are not training our children to love reading and to read widely, to speak more than one language. You know, in some communities here, people have to speak more than one language, right? But generally in the schools, let's say in Detroit, people aren't being taught to speak more than one language, or even to travel widely or read widely on the web. You know, because we don't want an activated citizenry in this country, the people who are sort of running things are happy running things, educating their children, and leaving the rest, leaving all that other genius fallow. So there are many levels at which I would say this engagement thing goes. I would say if people understood, if they felt that there was a real line to real power, then they would be engaged in a minute. If they think that this is here you come again, researching them, or asking them about something and nothing good's going to come from it, then maybe they're just going to try to go to work or just do whatever they can. Community organizing is a very powerful tool. Activation of people, just people understanding just a little bit their power, can become infectious. So maybe that's our role, is to let people know their power and then not try to give them the agenda, but learn the agenda from them. I'd be interested in your responses back. Yeah. Use the mic.
My understanding, where we come from, is what you mentioned, is the fact that if I don't feel I'm powerless, regardless of what it's done, then I have no voice, then I just give up completely.
Right.
So almost feeling powerless creates an environment of disconnect.
And sometimes we have more power than we recognize. So you're going to hear my Gardener's Tale. Probably everybody in this room knows my Gardener's Tale, but I'm still going to tell it, right? Because you have to listen with different ears so that you can feel confident telling it again. Do you know my Gardener's Tale? No? Okay, so that's all right. So I won't talk about it yet. But there is more, even though we have all of these structural things against us, so often we don't recognize the power right in our communities. There is a model that I learned about in Alameda County. It's called time banking. It was a community way of people, like if I'm good at gardening and you're good at tutoring and you're good at whatever, we can put our skills in a time bank, and then when I need what you're good at, then I can draw from that and then put it back. This is actually almost a way of cataloging the skills and talents and things in a community. It's a very interesting idea. I once had a project in Roxbury in Massachusetts, training local healthy heart advisors, community health workers around heart stuff. Of my 16, I think maybe 10 before had ever worked or anything. My little bit of training and then getting them to travel around in their neighborhoods and mobilize and home visits and all like that. Do you know that within 6 months, half of them had to leave because they had jobs? You know, it was just like the little bit of belief in themselves and that little bit of investment to overcome that hopelessness. So I think we need to invest in people and give them real power. I was talking earlier today. I see you in a minute. I'm using up all my time just on this little thing. I'm sorry, but let me just say one more thing, because we want to go deep, like with real ideas. I've lost this thought, so I'll go to you. Okay. Mike.
Okay.
They're taping it. I think they're taping it. So
I just want to follow up about the essence of power and how even apathy and powerlessness is still powerful, because there's still a decision of inactivity. So sometimes people think motion can only go forward, but you can go backward. And I've learned in my role as a community worker, I'm a social worker, that when you activate consensus, it generates commitment, it generates interest. Oftentimes, we are not aware of the privilege we wear when we come in as an administrator or as someone with a higher level education or as someone as an expert. And just by having that unseen privilege, regardless if we are the same race or class, it still creates a division. And when we don't enter into certain communities or circles with humility and just ask, then you are nurturing further disengagement or lack of curiosity. And I found just by asking, what do you think, how do you feel, it opens them up, because many times they're never asked that. And also just being, if you're not part of a community working within your city council going to your community board, you find out what's happening, and then also you can elevate the voice and the presence of the organization and the people that you're representing if they are not your neighborhood neighbors.
Thank you very much for that insight. And I think also the asking is, what are you doing in this community to solve the problems of this community? Because I tell you, people are not just sitting there doing nothing. There are people in all of our communities working to solve the problems. We may not see their efforts or may not even value their efforts, but people are not just sitting there trying to die, you know. And the other thing reminds me of what I had wanted to say. We need to set up ways of having community calendars of decision making. So when is the next school board meeting and what's on their agenda? You know, what is the state house, you know, what's the state legislature considering and what are they not considering? You know, different decision making bodies to make that very widely available to everybody when the meetings are, what's on the agenda, here's how you go, here's how you have input. And that might then start interesting people in running for the school board or the city council. I think right now the big wake-up call on November 9th was that we need to get more activated, even in terms of policy in the legislative process. So I wanted to, were there any other urgent things? I just wanted to raise two other questions with the clip before I dive deeply into a specific focus on racism. Sometimes I'm asked, why do we as a nation spend so much money on ambulances at the bottom of the cliff? If this thing that you're describing is real in terms of different levels of health intervention that we could access. And I have sort of a three-part answer to that. The first is that there's a lot of money being made down there at the in those ambulances, right? So, you know, hospitals, pharmaceuticals, medical device people, health practitioners, a lot of people making money down there. But I think a deeper answer is that we as a nation are very narrowly focused on the individual, so we don't even recognize that there's been a health problem until somebody falls off the edge of the cliff. That is, we are not using measures of how close is the population to the edge. You know, even like aggregate measures like income inequality or social cohesion or, you know, social networking. We need to develop more measures and use measures to understand aggregate level health things. The third thing is that we apparently are not convinced that an ounce of prevention is worth a pound of cure. I mean, and in fact, all of us in public health do know it's sometimes difficult to say how many cases of pneumonia you prevented today by X and X. You know, that proving the prevention of it's a difficult task, but we need to turn our heads a little bit more to that. I've also been asked, why are the greenies just launching themselves over the edge of the cliff? You know, like, why are they racing and throwing themselves over? Which, of course, they are not doing, right? But many people think that they are. They say, you know, why don't they stop eating all that fried chicken? Or why don't they this? Or why don't they that? And so there are two parts to that. First of all, we are so narrowly focused on the individual, again, that we don't see the systems and structures that are pushing that green population to the edge. Also, we are so ahistorical as a nation that we don't even understand how the cliff became three-dimensional, how the resources came to be differentially distributed and the population is differentially distributed. We don't even ask those questions. Sometimes we just act as if the present were disconnected from the past, right? And things must have always been this way because they were this way when I was born, right? Any other questions or comments before I, yes?
Thank you. I think this is a brilliant metaphor and analogy, and I'm wondering if you zoom out and ask the question of who created the cliff.
Right.
And because a cliff is, of course, sort of implies a naturalistic element to it, and I think one of the things that's so powerful about this is that you can zoom out and actually demonstrate how the cliff has been created through social, political, economic systems, and that there's nothing natural about it.
That's right. Thank you for that. And so, yes, and usually the cliff is created through historical injustices and then all of this stuff that's keeping the cliff. And some people have even suggested, well, one strategy would be to either build up the land here, which is a political strategy, right? And that's actually, you know, we spend 17%, I think was the last time I saw, of our gross domestic product in the U.S. on ambulances at the bottom of the cliff, you know, on health services, on all of this. And still our outcomes are like in the 30s, you know, infant mortality rate 31, and, you know, life expectancy at birth, whatever it is. Other countries don't spend as much on healthcare, but they spend more on social services and social support, social security, I would say. And what they're actually doing is building up the base so that the cliff is not as steep. And I have actually seen data where if you add what we spend on Social Security types of things plus health care, it's the same as what other countries spend on the two things combined. They're just getting better bang for their buck because they're investing where it matters as opposed to at the bottom of the cliff. So maybe that's the demonstration. Maybe that's the demonstration that we need, that an ounce of prevention is worth a pound of cure. Yes. Yes, you. Okay, waiting for a mic. Waiting for a mic.
Oh, there you are.
Oh, were you? Oh, Ayman. Oh, wait, let's get Ayman first.
I just wanted to say visually, the greenies should be standing on a higher cliff because their fall is greater.
Their fall is greater. Thank you.
It just visually, I know we all know that, but it's visually somehow if you can resolve it on the diagram. The other thing is,
yes.
The other thing is the percentage of people falling off the cliff puts such a burden on the community. So you have more people falling off the cliff. You had 5 people of the orangees, and only one of them fell off the cliff. Then there are four of them to carry the burden.
Right.
When you have 5 people and 4 of them fall off the cliff, it becomes extremely burdensome to the person that's staying on top, on the plateau. So the numerical thing puts such a burden on the community, and the height of the cliff, which of course relates to both biological and psychosocial reserves.
That's right. Thank you very much.
Our fall is bigger.
The fall is
when
bigger.
Our reserves are lower.
And also, somebody once suggested that it's more slippery at the edge, at the part of the cliff, near the edge. And with the greenies near the edge, every step that they try to take back is harder than a step that the oranges are trying to take back further away from the edge of the cliff. So not only is it higher, so that the consequences are worse when they fall, but it's harder to get back from the edge. So many things. People are always, thank you, people are always adding to my cliff. Yes.
I always want to ask this question, hear your opinion on that. All around the world, the discussion of public health, social determinants, is slightly different than how we discuss public health in the United States. The missing ambulance, missing nets, increasing consumer, all of racism, sexism, all of them are successful tools for capitalist economic model. United States of America is proud being the cradle of capitalist economic model. Yet, from public health perspective, we're still not discussing the impact of capitalism, how minorities, marginalized communities, working class people push to the edge as a mechanism, as a tool of capitalist economic model. How can we interject this discussion? How can we prove this discussion to the mainstream public health in the United States?
So that's a very important question. How to talk about capitalism in the middle of celebration of a huge celebration of capitalism, right? Even though people, and my rudimentary understanding, like when I talk about it, capitalism is when some people own the means of production and other people work there, right? And then you have, the disproportionate use, the usury of other people's labor for profit. So how can we, I put it in there as one of those things that creates and maintains that three-dimensional cliff. I think about social class itself as proximity to the edge or not. So when I talk about it, and so then you have to ask, why are some people closer to the edge? And then we get to institutionalized racism and all that. So when I put social class in here, it's proximity to the edge. But capitalism has differentially distributed the resources. I say the word all the time, every time I talk about this, but hardly ever does anybody engage me on that. So I haven't gone deeper. Do you have a suggestion? Do you have a suggestion of how we should talk about it? Yes, so please, in about 30 seconds.
All right. I think we should include discussion of the economic models, the impact of economic models, the social determinants of health, as in our core curriculum.
I don't think it's social. I think they're actually social determinants of equity.
Yeah.
Okay.
Yes. The other thing I suggest, I think it would work, is to raise awareness in the community level. When I talk to community members, youth, and I ask them about economic models, and I face just blank stares. They do not know, they have no idea what economic model we are in and what is the impact of different economic models. I think we should start with education.
I agree with that. I agree with that. Are there any other questions or comments? Because I've actually eaten up a whole lot of our time on this. So, okay, so now let's go to racism specifically as one of those social determinants of equity. When I say the word racism, what do I mean? I'm clear I'm talking about a system. So I'm not talking about an individual character flaw or a personal moral failing or even a psychiatric illness, as some people have suggested. But I'm talking about a system of power, and it's a system of doing what? It's a system of both structuring opportunity and of assigning value. And on what basis is the opportunity structured, and on what basis is the value assigned? It's based on so-called race, based on the social interpretation of how we look, which is what we call race in this country. So I'm hoping that everybody is clear that race is not encoded in our genes, right? There is no, we have mapped the human genome. There is no basis in the human genome for racial subspeciation. To just give you an example of what I mean about race as a social interpretation of how we look, here in New York City, well, at least right here in Harlem, I'm clearly black. I might be in a different part of New York City, and I might be clearly something else. You know what I'm saying already. But in Brazil, I'm clearly white in some parts of Brazil. South Africa, I'm clearly colored. Here, I could stand in different parts of the world with the same physical appearance, and the social interpretation of my appearance would put me into different racial groups. And furthermore, if I were to stay in any of those settings long enough, then my health outcome would probably take on that as a group to which I've been assigned, even though I'd have the same genes in all 3 or 4 or 5 places. And furthermore, I have to say, for everybody sitting in this room, there's someplace else on this earth where your so-called race is different from what you think it is here. Many of you have already experienced that, right? So, if that's what race is, the social interpretation, it's the social interpretation of how one looks. Racism is the system of structuring opportunity and assigning value based on that. It operates on race. The impacts are threefold. The first impact, when we do understand that racism exists, is that we understand it unfairly disadvantages some individuals and communities. But it should not take us long to recognize that every unfair disadvantage has its reciprocal unfair advantage, so that racism is also unfairly advantaging other individuals and communities. That's the whole issue of unearned white privilege that we hardly ever talk about because we value white comfort, right? And talking about unearned, unfair white privilege makes some white people uncomfortable. And I'm not trying to make anybody in this room uncomfortable, right? But I actually don't also value white comfort as my guiding principle. But anyway, there's a third impact of racism that we often don't acknowledge, and that's how it's sapping the strength of our whole society through the waste of human resources. So many examples. The reason right now that we're not vigorously investing in the full excellent public education of all of our kids is that many people in power, the blinders of racism have made them think that there's no genius in the barrios or the ghettos or on the reservations, like we can get along very well, thank you, without those kids. But of course, if we were to invest, there's genius in all of our communities, and we know that, and if we were to invest in that genius, we could be doing so much better as a nation, or even as a world. And I often say we might already be up on Mars farming if that were a good idea, if we were to invest in all that genius. But then we wouldn't even have to go to Mars. We could be solving the problems in our communities today if we were to invest in all of that genius. Another way that these same blinders that don't value all of us equally have affected our nation is that these blinders have made us complacent with what I describe as a wholesale warehousing disproportionately of so many black and brown men in our prison system, as if that did not separate us from human potential. And if you know folks involved in the system, you know that there are many geniuses who caught up in this system that if there had only been some other way could be contributing quite productively to our society. I actually think if I were going to ask you all as students and researchers, which of these 3 impacts of racism I think is most urgent for us to research now or to have media stories about or conversations around our dinner tables about, is that third point, about how racism is sapping the strength of the whole society. because we need to get more people feeling and understanding a sense of urgency to dismantle this system and put in this place a system in which all people can know and develop to their full potential. Before I leave this slide, there's one more thing. When I was at CDC, I was at CDC happily for 10 years and there for another 4, okay? And, right, and the last 4, I was in a different part, and those people did not think that racism belonged anywhere on CDC's agenda, and if it did, it certainly didn't belong in their division. And the Associate Director for Science instructed me, I had already talked about unfair disadvantage, I needed to take that point about unfair advantage off of my slide. And then when I refused, he says, we came to a compromise-ish, which was that I was to take the words unfairly off of both. And then if I could talk about disadvantage and advantage as long as I didn't characterize either one as unfair. And my understanding from that interaction was this. There are some people who think that there is disadvantaged and then there's normal, right? Disadvantaged and normal. And that's because we are ahistorical and people do not understand that their normal is built up on a whole mountain of unfair advantage. And that's a very important point for us to communicate to others. How many of you are familiar with this story? A few. Okay, so here we go. So this story, Dual Reality, a Restaurant Saga, is to help people understand racism, of course. So this was sparked by my own real experience when I was a medical student. I was studying with some friends in my apartment, and we were studying long and hard, and it got late, and we got hungry, and I, of course, had no food in the apartment. So we decided to go into town and find something to eat. We go into town, we find a restaurant, we go in and we sit down, the menus are presented, we order our food, food is served, here we are. Ta-da! And you're like, what am I supposed to make of that? Okay, so the story's not over yet. As I sat there with my friends, I looked across the room and I noticed a sign, and the sign was a startling revelation to me about racism. So I hope you're curious. What did the sign say? What did the sign say? I'll tell you what the sign said. It said open. So now I've lost most of you. Let me recap. Here we are sitting, eating in this restaurant. I look across the room. I see a sign that says open. If I hadn't thought anything more about it, I would have assumed other hungry people could come in. The nature of those signs, I recognized that indeed the restaurant was closed due to the hour, and that hungry people just a few feet away from me, but on the other side of the sign, would not be able to come in and sit down and eat. And then I understood how racism structures open-closed signs in our society, that racism structures a dual reality. And for those who are inside the restaurant, sitting at the table of opportunity, eating, and they look up and they see a sign that says open, they do not even know that there's a two-sided sign going on, because it is difficult for any of us to recognize a system of inequity that privileges us. It is difficult for men to recognize male privilege and sexism. It is difficult for white Americans to recognize white privilege and racism. It is difficult for all Americans to recognize our American privilege in the global context, except we got a little taste of it with Ebola, did we not? Right? Yes, for those on the other side of the sign, they're very well aware there's a two-sided sign going on because it proclaims closed to them, but they can look through the window and see people inside eating. So back inside the restaurant, to those who say, is there really a two-sided sign? Does racism really exist? I say, I know it's hard for you to know when you only see open. In fact, it's part of your privilege not to have to know. But once you do know, you can choose to act. So it's not a scary thing to name racism. It's an empowering thing. In fact, it doesn't even compel you to act, but it does equip you to act, so that if you care about those on the other side of the sign, which is an if, but if you do, then you could even talk to the restaurant owner, who is, after all, inside with you, and you could say, well, why don't you open the restaurant again? There are hungry people outside. Let them come in. You'll make more money, and oh, the conversations we can have. Or maybe what you'll do is pass food through the door, or maybe you'll break the glass or tear down the sign, but at least what you won't be doing is sitting back saying, wonder why those people don't just come on in and sit down and eat, because you'll understand something about the two-sided nature of the sign. And so we could have, I'm not going to do it now, but we could have a 3-hour conversation right now about how could people born inside the restaurant know about the two-sided nature of the sign. If we have time, let's come back to that, okay? But I want to carry on now and say, many of you Who is not familiar with the Gardener's Tale? Who has never heard the Gardener's Tale? You said you didn't. Raise your hand. Oh, okay. Is there anybody here who's never heard the Gardener's Tale? Okay, so a few. Okay. So I'm going to do, this is going to be a quick Gardener's Tale, because I only have 25 minutes, something like that. I find that when you're trying to figure out how does racism turn into a health outcome, so, how does it turn into differences in asthma prevalence by community or obesity prevalence or anything like that, it's useful to try to understand racism on 3 levels: institutionalized, personally mediated, and internalized. I will define each of these levels, very quickly give you examples of how they impact health, and then illustrate them with my Gardener's Tale allegory. Institutionalized racism is the system, if you will, the constellation of structures, policies, practices, norms, and values that taken together result in differential access to the goods, services, and opportunities of society by race. This is the kind of racism that does not require an identifiable perpetrator because it's been institutionalized in our customs, laws, background norms. It often shows up as inherited disadvantage or its reciprocal inherited advantage, and we see it in terms of material conditions and in terms of access to power. Examples include differential access by race to housing, education, employment, income opportunities. Differential access to medical facilities, including linguistic access. Differential access to a clean environment, including the differential placement of toxic dump sites or bus transfer stations in communities of color. In terms of power, differential access to power as information about medical stuff, or information about our own histories. Power as resources, not just capital resources, but social networking resources, knowing somebody on the board. And power as voice in government, media, and the like. Now, I want to pick up a question that I'm often asked, which is, let's say, Dr. Jones, look at that top line of examples: housing, education, employment, income. Dr. Jones, isn't that what we call social class? Why do you have that on a slide about racism? Are you talking about racism, or are you really, really, really talking about social class? And there might be many people in this room who are like, yes, that's my point exactly. Please explain that to me. So I am. So I start with the observation that it doesn't just so happen that people of color in this country are overrepresented in poverty, while white people in this country are overrepresented in wealth. That is not just a happenstance. And for each marginalized or stigmatized or oppressed group of color, there's been some initial historical injustice. So for American Indians, it was the taking of the land, right, and the near genocide, and moving the survivors to reserve lands, reservations, and then in some instances, something good was found under one reservation, you got to pick the people up and move them somewhere else. We could go through a whole litany of groups. We could go through people who lived in Mexico for centuries who never crossed the border crossed them, and they found themselves in New Mexico, in California, and their great-grandchildren are being harassed right now today. Or we talk about the usury of migrant farm labor, and all of this, differential immigration stuff. We could talk about that with Chinese laborers, centuries ago, who were brought to build our railroads, unable by law to marry, unable by law to bring their families with them. We could talk, about Japanese people interned during World War II and how we fear that the same thing might happen under this current regime, right, from people of Middle Eastern North African appearance, or looks like Muslim or whatever, right? When you think about people of West African descent, the original historical injustice was the kidnapping of West African people and our importation across the Atlantic with tremendous loss of life in the Middle Passage. And then for the survivors and their progeny, for generations, what I describe as the coerced usury of our unpaid labor for centuries to build this country. But then sometimes people hear me talking like that, and they're like, please, Dr. Jones, there you go talking about slavery. Dr. Jones, we all recognize that slavery was an unfortunate chapter in our nation's history. But Dr. Jones, the enslaved people were emancipated by 1865, and we're in 2017, so that makes that 152 years ago. So all else being equal, Dr. Jones, don't you think that the impacts of racism, not of racism, but of slavery would have washed out by now? Now, the answer to that question is in the question, because all things have not been equal since 1865, and all still is not equal today, and there are contemporary structural factors that are perpetuating each of those initial historical injustices. And those contemporary structural factors are part and parcel of institutionalized racism. So that when you ask me, am I talking about social class or am I talking about racism, My answer is that institutionalized racism explains why we even see an association between social class and race in this country. It's a crucial aha. It's a very important aha. And it's not to say that I'm not concerned about eliminating white poverty. We need to address white poverty, black poverty, Latino poverty, American Indian poverty, Asian poverty, all poverty. I am right there. In fact, I'm right about eliminating income inequality. We sort of had a little bit of discussion about that before. My husband doesn't agree with me on that, but okay, there it is. So, right. If I had a magic wand today, I could eliminate income inequality across this land. But even if I had that power and used it, if I did it without addressing the background structures, policies, practices, norms, and values, the mechanisms of institutionalized racism that are deeply embedded in the fabric of our nation and were put in place to differentially shunt different populations into different possibilities, if I eliminated income inequality today but did not address institutionalized racism, then in 20 years, in one generation, we start to see a stratification by race again in terms of income. So this is not an either-or question. This is a both-and. Before I leave institutionalized racism, I also need to say that it can be through acts of doing, acts of commission, as well as acts of not doing, acts of omission, and very often institutionalized racism shows up as inaction in the face of need. The second level of racism, so for those of you who know the Gartner's Tale, is it useful to hear me go through all this detail? Is it interesting? Yes? Okay. Because I could go faster and skip over stuff. No? Okay. Okay. So personally mediated racism I define as differential assumptions about the abilities, motives, and intents of others by race, and then differential actions based on those assumptions. So this is what most people think of when they hear the word racism. Somebody did something to somebody. It includes the different idea, the discrimination, the prejudice, and then the different action, which is the discrimination. Some people call this interpersonal racism. I call it personally mediated racism because I am still understanding racism as a system. And this is the system mediated through people. Includes all the, now we're talking about implicit bias, unconscious bias, all of that is in here. How could it impact health? Well, I am not going to dwell on the police brutality because I could stay there for 5 minutes, just giving you a list of names of people, unarmed black and brown men and women who've been killed by police, who have come to national attention. I don't know all the people here in New York last weekend. You know what I'm saying? All I have to say about this is that police brutality not only takes away the genius and the loving spirits of people who are killed, it not only shatters families of those who are killed, but there are whole communities who are just bracing ourselves for the next occurrence. Because for the most part, there's been insufficient accountability on the part of police departments for these actions. And that bracing also has impact. Physician disrespect could be as subtle as a physician not giving a patient the full range of treatment options because the physician figures the patient couldn't afford, understand, comply, or it could be quite blatant, like sterilization abuse. Shopkeeper vigilance, being followed around in stores, waiter indifference, not getting quick respectful treatment, that's part of everyday racism. The microaggression, subtle communication of disrespect. That might be related to elevated blood pressures in communities of color. Teacher devaluation, very important. If a teacher looks at a young child and thinks, that child can't learn, and puts them off in the ADD track, that child won't even know their full potential, much less have the opportunity to develop to their full potential. Like institutionalized, personally mediated, can be through acts of doing, acts of commission, as well as acts of not doing, acts of omission. But more important here is to recognize that personally mediated racism can be unintentional, as well as intentional. You do not have to have intended to do something racist to have had a racist impact. The third level of racism, internalized, here I'm defining from the point of view of members of the stigmatized races as acceptance by members of the stigmatized races of negative messages about our own abilities and intrinsic worth. I have been challenged by my colleagues who do anti-racism training to say, what about the internalized sense of entitlement that many white people walk around with? Isn't that also internalized racism? Yes, it is, I agree. I, for a long time, did not understand how that entitlement could result in negative health outcomes. I'm thinking more about it, but I don't have time to talk about it today unless somebody asks me a question, okay? But from the point of view of members of the stigmatized races, self-evaluation turns into feeling maybe I'm really not as good as. Maybe I shouldn't try to graduate from high school or apply to that college or try to get that job or live in that neighborhood. White man's ISIS Coulter syndrome. If you never heard that phraseology, let me tell you, it's a real phrase from my parents' generation. What it meant then for people of color, it still means for many of us today. So say you're black and you need a lawyer, maybe you'll go and seek out a white lawyer. Or if you're sick, you might prefer the white doctor. Or in fact, if your lemonade were warm, you might go way down the street to get the white man's ice over the black man's ice, deeply believing that the white man's ice is colder, deeply internalizing the myth of white superiority. Resignation, helplessness, hopelessness turns to a lot of self-destructive health behaviors, turns into not registering to vote, lots of bad stuff. It's about accepting limitations to our own full humanity as a box into which we've been placed. So here's the Gardner's tale that illustrates these three levels of racism and helps us know what to do. Sparked by an experience in my own life, my husband and I have been newly married, moved down to Baltimore. I'm going to finish my PhD, bought our first freestanding house, big wraparound porch. Around that house, flower boxes dotting the porch. Lovely. Bought the house in October, not the time to plant, but spring comes. My husband loves to garden. He runs out with our marigold seeds, and then he runs back in the house because he says, you know, we have dirt in some of the boxes, but some of the boxes are empty. I'm going to have to go to the gardening store. So, okay, fine. So he goes down to the gardening store. He hauls back big old bags of potting soil. We fill up the empty boxes. Then we take equal numbers of marigold seeds, put them in each of the boxes. We water all the boxes. By this time, I'm exhausted. I'm not the gardener. I sit back, going to be delighted. 3 weeks later, walking out of my front door, I look at these flower boxes on my porch, and I literally stopped in my tracks. Because what I saw with my own eyes made me think that we had planted completely different species in some boxes versus others. Because some of the boxes were full of plants. And they were strong, vigorous-looking plants. And some of the boxes just had a few plants in them. And they were scrawny, scraggly-looking. And then I realized what had happened. That potting soil that my husband had bought turned out to be rich, fertile soil, so that every single seed planted in the potting soil had sprouted. The strong seed had grown tall and vigorous, and even the weak seed had made it to a middling height. And I hope those of you who are very familiar with the gardener's tale, are you listening to the nuances of the storytelling? Because I want you to listen to the nuances of the storytelling so you can tell the story back with confidence, right? Okay, in that old soil that we found there, it turned out to be poor rocky soil. So the weak seed in the poor rocky soil just died, and even the strong seed in the poor rocky soil had to struggle to make it to a middling height. So there's some of you all nodding in the audience, so maybe you're gardeners. Maybe you've composted half of your garden. You know, what time is it? Okay. So maybe you've composted half your garden, so you know the image I'm talking about. The image that I'm describing is the image of the importance of the soil, the importance of the environment, right? But now I'm going to make this a story about racism by introducing a gardener who has two flower boxes, one which she knows to have rich, fertile soil, and one which she knows to have poor, rocky soil. And she has seed for the same kind of flowers, except some of the seed is going to produce pink blossoms, and some of the seed is going to produce red blossoms. And the gardener prefers red over pink. So what does she do? She takes the red seed and puts it in the rich, fertile soil, and the pink seed in the poor, rocky soil. 3 weeks later, she sees in her flower boxes what I saw in mine. That rich, fertile soil, all the red seed sprouts, strong red seed, tall and vigorous, weak red seed makes it at least halfway up. Poor rocky soil, the weak pink seed dies. Here comes a strong pink seed struggling to make it to a middling height. And then in those two flower boxes, those flowers go to seed. And the next year, the same thing happens. And then those flowers go to seed. And year after year after year after year after year, same thing happens. So finally, about 10 years later, the gardener's looking at her flower boxes, and she says, you know, I was right to prefer red over pink. So we interrupt the story there to say the first part of this story is how institutionalized racism works, where you have the initial historical injustice of the separation of the seed into the two types of soil, the contemporary structural factors of the flower boxes keeping the soil separate, and then through inaction in the face of need, perpetuation of the inequity. But let's pick the story back up to say, well, where is personally mediated racism in the garden? Well, the gardener is looking over the red flowers thinking, ooh, red is beautiful. And then she looks at the pink flowers. She says, oh, those pink flowers sure are scrawny and scraggly, so she plucks off the pink blossoms before they can even go to seed. Or maybe she notices that a pink seed has blown into the rich, fertile soil, so she plucks it out before it can establish itself, which is some of the anti-affirmative action stuff that goes on. And where would internalized racism be in the garden? Well, the red flowers are just living their lives, enjoying being red, many of them not either understanding or acknowledging that they're benefiting from enriched soil. Pink flowers are looking over at red, thinking red is mighty fine, and wishing with all their hearts that they too could be red. And here come the bees minding their own business, collecting nectar, but of course they're pollinating at the same time. So here comes a bee into one of the pink flowers and to another pink flower, and to this pink flower, and this flower's like, get away from me, bee, don't bring me any of that pink pollen. I prefer the red, because the pink flower has internalized that red is better than pink. So now the question arises, what do we do to set things right in this garden? Well, We can start by addressing the internalized racism. So we can go over to the pink flowers and we can say, pink is beautiful, power to the pink. And that is an important intervention. That is an important intervention. That's the point I was going to make for you who said you didn't remember the Garfield. It is an important intervention. But if that's all we do, it's not going to change the situation in which the pink flowers find themselves. So you say, okay, let's address the personally mediated racism. Let's have a conversation with the gardener. Or better yet, let's have a workplace multicultural workshop for the gardener. It's all good. So we have our workshop, and in the workshop we say, dear gardener, would you please stop plucking the pink flowers? And maybe she will, and maybe she won't. But even if she does, it's still not going to change the situation in which those flowers find themselves. If you really want to set things right in the garden, you need to address the institutionalized racism, which means you have to either break down the boxes and mix up the soil, or if you want to keep separate boxes, that's all right too, although it makes it easier for the gardener to continue segregating resources going forward. But if you decide to keep separate boxes, what it means is that you have to enrich that poor rocky soil until it is as rich as the rich fertile soil, and when you do that, the pink flowers will flourish. They'll be looking beautiful, grand, and glorious. So that in that intervention on the institutionalized racism, you'll also have addressed the internalized racism. Because pink will no longer be looking over red, thinking red is better, or wanting to be red. And in that intervention on the institutionalized, you may also address the personally mediated. Now, let me tell you, the original gardener may have to go to her grave preferring red over pink, but her children who grow up and see the flowers equally beautiful will be less likely to have that kind of attitude. So the story has been to illustrate these three levels of racism and strongly suggest that if we want to set things right, we need to at least address the institutionalized. Good to address all the levels at the same time, but at least address the institutionalized. Now, this is the part that I haven't come to yet. Who's the gardener? After all, the gardener is the one I gave the power to decide, power to act, and control of resources. Well, certainly government's a huge part of the gardener, not the only part. Media, foundations, corporations, communities to the extent that they have self-determination. But whoever the gardener is, it is dangerous when the gardener is allied with one group. I painted her red. That's why she prefers red over pink. And it's also dangerous when she's not concerned with equity. When she can look at her flower boxes and think that her flowers are beautiful, thank you, because she's not even counting the pink flowers as part of her garden. And so our challenge is what to do about the gardener. Do we make the gardener striped, polka dotted, fuchsia? Many questions can come out of this. I want to just share some questions that have come up in the past, just two questions, and then I'm going to race to the last thing I want to say. I was once asked, Dr. Jones, excuse me, why should the red flowers share their soil? I loved that question. Why should the red flowers share their soil? The reason I love that question is because it showed me the power of this story to start conversations about racism that would be otherwise difficult if we were talking about racism between you and me. My answer to that question, why should the red flowers share their soil, is that actually that soil doesn't belong to the red flowers, it belongs to the garden. Right? Another question, what if that's not the gardener's, what if that's not the original gardener we're looking at? What if that's the gardener's great-great-great-great-grandchild? Here we are, what then? Right, because the great-great-great-great-grandchild has grown up seeing those flowers looking like that, may not even think there's a problem to be solved. So we must make the differences in the height and vigor of the pink and red flowers a problem requiring urgent solution. We need to then, if we're going to try to solve it, make those flower boxes transparent. We need to be talking about the differences in the quality of the soil. And when we make the flower boxes transparent, we have to be crystal clear that the pink seed did not just go launch themselves into that poor rocky soil. So we have to talk about history. We have to talk about the gardener's agency in setting up the whole situation, how her preference for red over pink set up the whole situation. That is cultural racism, if you will, or white supremacist ideology in our current setting. And we must talk about that because for many years, this was only about the quality of the soil, my story, until I realized that even if we were to compel the gardener to equalize the soil today, if she continued to prefer red over pink, then she would continue to privilege red over pink going forward. So we must deal with both parts of racism, the opportunity structure and the value assignment. I am sorry that I will not be able to go into more detail on these things. I just want to say that there are many axes of inequity operating in our society today. I recognize all of this. Race is not the only axis of inequity in racism system. The definition that I gave you of racism, actually I'm going to go back. This definition of racism can be a definition of sexism. What's sexism? A system of structuring opportunity and assigning value based on gender that unfairly disadvantages, unfairly advantages, and saps the strength. So there are many axes. Why do I think it's so important for all of us to name racism as how is it operating here and organize and strategize to act? It's because racism is foundational in our nation's history, and yet many people are in denial of its continued existence and profound impacts on the health and well-being of the nation. So even as we're working on all of these other axes of inequity, and systems of structural inequity, we must all address racism, I think, if we're going to set things right. I have a three-part definition of racism. I just want to highlight that last bit, the middle part. How do we get to health equity? If health equity is assurance of the conditions for optimal health for all people, a process, not an outcome, how do we get there? It's going to require valuing all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources not equally but according to need. There are three huge barriers to achieving health equity in our country. We narrowly focus on the individual, which makes systems and structures invisible or irrelevant. We're ahistorical. We act as if the present distribution of advantage and disadvantage were a happenstance. And we endorse the myth of meritocracy, the story that goes something like this: if you work hard, you will make it. Clearly, most people who've made it have worked hard, although not everybody who's made it has worked hard. But most people who've made it have worked hard. But there are many, 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 many other people working just as hard or harder who will never make it because of an uneven playing field. And racism and all these other systems of structural inequity have created and are maintaining that uneven playing field. So when we are in denial of racism, which we can do two ways, you can say, I don't think racism exists, or you can be silent and never say the word. And then you're complicit with the denial that's widespread in this nation. When we're in denial of racism, then we're doing that. I wanted to let you know about an international anti-racism treaty that the U.S. signed and ratified. And we have obligations to act under it every 6 months. Every 6 years. Every 6 years, the State Department submits a report to a UN committee. Committee sends back its concluding observations. I want you to read this 14-page document. It starts, Dear United States, thank you for your report. We remain concerned about racial profiling, residential segregation, the achievement gap in education, differential access to health care, disproportionate incarceration, on and on and on. It's a 14-page document that can be used for community organizing. It also says, Dear United States, you need a national action plan to combat structural racial discrimination, and you need to let your people know about the existence of this treaty. I know that I am past time, so I'm not going to tell you the last story, but I encourage you all to name racism, ask how is racism operating here, and then organize and strategize to act. I'm so appreciative of your time and attention. Thank you very much. Do we have any time at all for questions? We do. Okay. So any questions or comments? What time is it right now? I don't have it.
It is the right time.
It's the right time. Okay. So we can go back to some other stuff. So I'd love to have your questions and comments now. Did anybody have anything to add to the gardener's tale? I love to always learn from the gardener's tale.
In this case, the flower needs to know that it's in a flower box around the house. And having one side of the house with flowers and the other without, this doesn't make it healthy.
That's right. Absolutely. Right. And the gardener doesn't care. But so now, do we need a garden committee? Do we need a judge who's judging this house compared to the next house and the next house? Does the gardener need to go down the street to other houses and find out how they're doing things? So like international, reaching out to other countries to learn. We are so American exceptionalist that often we think we know best and that there's nothing for us to learn, but you're absolutely right. Yes.
What you think about people, like white people trying to be allies,
Okay.
and I think I've heard some quotes from you on this, and
Yes.
I'm struggling with it myself, and I'd love to hear what you think.
So first of all, I welcome everybody in partnership around this struggle. I don't think that white people are allies, because they're not allies to my struggle. This is their struggle too. So I think about all of us, kind of partnering together. So I don't like the term white allies. I think it's important for white people to recognize their white skin privilege in talking to other white people about racism. I can tell stories all day long, and it will not have the same impact as a white person, raising racism, saying the word, or questioning processes and stuff in a meeting where there are just white people in there. So you have that power. The other thing, some people say, oh, but now you go talk about white skin privilege, and don't give me that. I grew up in Appalachia, or I'm poor, I don't have white skin privilege. Don't talk to me about that. I'm not privileged at all. I have to say this. If you are living as white in this country, you have white skin privilege. You might be dogged on other aspects of life. I'm going to give you an example of somebody who understood that and used it. About 2.5 years ago in McKinney, Texas, outside of Dallas, you may remember this, there were some young teens who were celebrating one of their birthdays at a swim club in one of their neighborhoods. And so they went into the swim club. People who were there objected to their being there, and they called the police. And what we saw was a police officer dragging this young black girl and then sitting on her. And we saw the young black boys sitting on the curb with their hands handcuffed behind their backs. How do we know about that? Right, a white kid. I didn't even know that until the next day. There was this young white boy I heard interviewed the next day saying it was almost as if I were invisible to the police. He was one of the friend group at the party. He saw what was happening to his friends. He could have run home for safety, like time for allyship to be over about now, right? Getting a little dicey up in here, right? But instead, he recognized that his white skin privilege made him almost invisible to the police. And he stood right up there and videotaped what was happening to his friends. So it's not for you to try to deny your white skin privilege. If you are living as white in this country, you have it. The challenge for you is to use it for the struggle. I also want to just say one more thing. I had the experience, so at CDC, we were investing once in a project that was going to do job training for poor black and white women in North Carolina. So I had a colleague at CDC who was all about addressing social determinants of health, but she would hardly ever talk about racism because she thought me talking about racism, I didn't care about poor white people, right? So that's how the cliff became three-dimensional, actually, was in a conversation with her. But we were doing this project. CDC was going to make a site visit. I wasn't going to be able to go. I said, okay, please take these 5 slides for me on racism. And she pushed back. She said, Camara, why do you want me to talk about racism in this context? The thing that all of these people have in common is that they're all poor. And I said, well, actually, they have 2 things in common. They're all poor, and they all live in a racist society, but they experience that second thing differently. That is the most important thing for us to convey, to understand the 2-sided nature of that sign or multi-sided nature of that sign of racism that creates a dual or multi-sided reality. And sometimes it's very hard for people to understand that just feet away from them or somebody they know, a colleague, they're having a very different experience in the same place. Feet behind in a store, for example, or whatever, and see how they're treated compared to how they're treated. I mean, you have to believe. The other thing is we need to be interested in the stories of other people, and we need to be interested, we need to believe them. Don't just say, oh, well, that one is sensitive or has a chip on their shoulder, and then we need to be willing to join in the stories of others. I think one of the biggest things we need to do is burst the bubbles in which we all live. Every single one of us lives in a bubble of our school and our neighborhood and our family, and maybe we have a religious affiliation or a social club or whatever. And some of the bubbles are quite large and very thin soap bubbles. Some of them are very small and thick plexiglass, but all of us are in a bubble. And in our bubbles, we often don't know that just across town, there's somebody who's just as kind, funny, generous, hardworking, smart as we are, who is living in very different circumstances. And when we burst our bubbles, we will understand our common humanity in different circumstances. And I think that that's going to be one way to help us start sharing resources and at least caring about one another more. So I don't know how you guys, I don't even know how the school bursts bubbles. I don't know if there's, you get people out, but institutions can do that. Private and public schools can partner and share 7th grade science classes. I mean, there are ways that we need to be bursting these bubbles. Sir?
Well, first of all, Camara and I served together on the board of the American Public Health Association for years, and I know her passion is without limit, and her advocacy is absolutely beyond the clouds. We need to burst the bubble by keeping that conversation going and being respectful of all voices. Even as recently as our commencement last year, we had to go through a self-examination in terms of allowing freedom of speech and respect across the board. And there are always lessons to be learned. But what I used to teach a course on vulnerability in health. And one of the major elements is that advocacy can never replace representation. I I can be the best advocate for you.
That's such a
but
good.
I will never.
Can we be heard? Okay.
I can be heard so long as I stand by you. And that's another metaphor for tonight. Thank our speaker for tonight, a champion for humanity.
Thank you all. Thank